Thank you everybody for joining us today. I'm excited to have Dr. Backel here to present part of a series, Implementation and Practice for Pediatric Weight Management. So what we're going to do is he's going to get started here in just a second, and please hold your questions until the end, at which point we will unmute you should you have any questions to ask Dr. Backel. But without further ado, I'm going to turn it over to him.
Okay, thank you so much, Sarah, for giving me this opportunity to talk to you all. I'm not sure who you are, but I thank you so much for joining this webinar. And I'm not sure what kind of centers you guys are working in, if it's here in the Chicago area or in a rural area. But I hope that my experiences in the last 7 years at Lawndale Christian Health Center could help you and motivate you and encourage you in the work you're doing with children. And I am a pediatrician. I've been working at Lawndale Christian Health Center for the last 7 years. And I want to talk to you today about pediatric weight management in a community health center in an underserved urban neighborhood. So now my screen just froze. There we go. All right. This project is funded by a grant from the Alto S.A. Sprague Memorial Institute and the Illinois Department of Health Care and Family Services. And I have no relevant financial relationships with the manufacturers or any commercial products I'm going to be discussing in this talk, and I'm not going to discuss any commercial products or services in this presentation. The objectives I have for this talk is for all of us to recognize the barriers that families face in being healthy, and also to recognize the importance of getting an entire family involved in lifestyle change, as well as recognize the impact healthcare providers and support staff have in empowering families to be healthier. My main points will be to talk about obesity in general, and then some of the barriers that our patients face and we as providers also face. And then specifically, I'm going to talk about my experience at Lawndale Christian Health Center and about the weight management programs that we have there at our clinic. First of all, I want to talk about obesity in general. We all know that it's an epidemic, and it's a serious public health problem here in the U.S. and around the world. The prevalence has more than tripled in the past 30 years. 31% of our children and adolescents are now overweight, and 17% are obese. And there's also a large discrepancy between the minority groups and whites. So 37% of African Americans are overweight, 41% Hispanics, and 28% whites. These are the obesity trends in U.S. adults. You've probably seen these charts from the CDC. As we see in the last 20 to 30 years, we have a dramatic increase in adult obesity. But recent data from the CDC showed that even in very early childhood, 9.5%, for instance, of our infants are more than 95th percentile for weight per length, since we don't measure BMI less than 2. So weight per length is more than 95th percentile. 31.7% of children and adolescents ages 2 through 19 were more than 85th percentile. 17 were more than 95th, and 11.9 were more than 97. And the trends are telling us that perhaps overall obesity rates are stabilizing, but the very obese, the 97th and 99th percentile obesity is still increasing. And then rates among preschool children, 1 in 7 low-income preschool-age children is obese. So it's not just something that's affecting our school-age children and teenagers, but it's now affecting our infants and preschool children as well. And even in those states that have lower obesity rates, like out in the West, even within those states, the counties with higher prevalence of low-income populations have increased obesity rates. Now I want to talk about some of the factors that influence the rate of obesity. We have our environment, of course. the community that we live in, that our patients live in, the neighborhood, how it's perceived, how safe it is, if it's fine for kids to be out walking, running around, playing. We've also seen that there's disparities between different races, so genetics plays a large role. If your parents or grandparents are obese, the likelihood that you will become obese is higher. And then also income and poverty play a role. The higher the income in this country, the less likely you will be to be obese, versus the poorer people here are obese. And interestingly enough, in very poor countries, that's the opposite. In poor third world countries, the rich are the ones becoming obese, and the poor are still battling starvation. Then, of course, the food that we eat and our children eat play a huge impact in the rate of obesity. And then education, how well our parents of our patients understand what it means to be healthy and eat healthy. So it is an epidemic of the 21st century, and it is a more complex epidemic than some of the epidemics that we have faced in the past, like vaccine-preventable diseases. So there's no vaccine that is available for obesity. So it's a very complex problem, and we need a complex solution to deal with it. So it is a medical issue because of all the comorbid conditions that affect kids and adults that have obesity. There are psychological implications of how people perceive themselves and their children that are obese, and then also all the bullying and the problems that go on with kids that are obese in school. There's social factors. If the society as a whole is becoming more obese, the perception that oneself is obese is less and less. And then there's also political implications and financial implications. If all these comorbidities keep increasing, our healthcare costs are rising, and a lot of political initiatives also have been raised in the last years, especially to try to battle this epidemic. So therefore, a medical, psychosocial, political movement is needed to tackle this epidemic of the 21st centuries. So we're facing a lot of barriers to do that, and one might be wondering, what can I, as a medical provider, be doing about this huge epidemic that we're facing in this country? And so I want to talk, first of all, about some of the barriers that we are facing, our patients are facing, and then how to address some of those. First of all, the family lifestyle. A lot of our families are working. The parents are full-time. They have full-time jobs. A lot of our parents are single parents, so there's no time to cook. There's no time to be home. So it's much more convenient to pick up fast food on the way home. And there's also less control over what children eat when you're not home with them. So a lot of kids, they spend time in schools, babysitters with grandparents, etc. And then there's also increased availability and access to junk food, be it fast food or corner stores or so on, or grandmother having cookies and ice cream and so on available. And then excessive screen time. With all of our devices that have screens these days, it's becoming more and more of an issue. Poverty, like I said, does play a role in obesity. Healthier foods, such as fruits and vegetables, do tend to be more expensive, and junk food is more available, especially in poorer neighborhoods. Such areas are called food deserts, where areas that lack access to grocery stores that sell healthier food and beverage options. And then neighborhoods also play an impact on obesity rates. So if you have a neighborhood with gang violence, traffic problems, lack of safe areas such as sidewalks, bike paths, and green space for families to exercise in, it becomes more and more challenging for families to actually do things to prevent obesity. And then a lack of amenities such as parks, YMCAs, after-school programs, etc. And then there's the whole concept of perception versus reality. Even though you might live in a fairly safe neighborhood, if perhaps one little incident happens in your neighborhood, you might already think your neighborhood is not safe and you're going to keep your kids inside. So in actuality, maybe your neighborhood's pretty safe, but your perception of that neighborhood is not so. Schools also can be a barrier. They can be an issue. Thankfully, here in Chicago, the Chicago Public Schools have, last year, they reinstated the recess time, at least 20 minutes. and hours of PE are also being increased, but it's still a problem. Kids are just not active enough at school. There's lack of funding for athletic and physical education equipment, and especially in inner city schools, they often don't even have the space around their schools to be able to let the kids go out. Then there's the fear of litigation that something would happen on playgrounds, and the whole issue of school lunches. They are being addressed, but we still have a long way to go. Then the issue of access to health care. There might be lack of medical insurance. Thankfully here in Illinois we have an all kids program, so none of our kids should lack medical insurance, but perhaps parents of children don't know that. There might be geographically distant locations, especially if you're in rural areas. Lack of transportation. The issue of language, cultural barriers. I work mostly with Hispanic patients. So if patients cannot speak any English, they might just rather go to their local pharmacy or their local healer before they come to our clinic. There might be mistrust in providers, and the issue of illiteracy. And then education and involvement in the child's life is also a barrier. If a parent does not see the importance of healthy living as a means to prevent future chronic medical conditions, then it's highly unlikely that they would be motivated to make changes to make their children healthy. They often have the inability to link cause and effect of chronic medical conditions to a future outcome. They only live day by day. They don't realize that having a obese 4-year-old that might develop diabetes at age 12 actually will have negative health impacts on the future. And then also the lack of role models. If everyone in your family is obese and eating junk food, then it's very difficult to be different. And then also beliefs that are prevalent in certain cultures, traditions, family. Again, if everyone around you eats a certain way, it's very hard to break out of that and to be different and to try to be healthier. Media. The commercials that kids see on TV often promote junk food, and then a lot of parents, they do see the need to make a difference, but they have this sense of helplessness in attempting to affect change because they think anything they do doesn't work anyway. An interesting concept that Steve Whitman over at the Sinai Health Institute found when they did their health analysis of a neighborhood is the issue of perception and this abnormal norm. So in areas of high obesity prevalence, the recognition of obesity in oneself or one's family member becomes under-recognized. In other words, the higher the parent's BMI, the less likely that parent will see their child's BMI as unhealthy. And then also the denial of the fact that unhealthy lifestyle and result in chronic diseases are indeed problems. If everyone in your family is obese and they're not suffering visible consequences, they don't have the insight that something is wrong here. Not only do our patients face barriers, but we as providers also have barriers. One of them might be lack of motivation to counsel patients on healthy living. We might think that anything we say will just probably go out in one ear and out the other. Anything we say is useless. We're not getting reimbursed for it. We only have 15 minutes to see our child for the well-child visit. So we might lack willpower. We have this time constraints, and our own health and our own lifestyle and BMI might affect the way we talk to our patients. So there's a lot of barriers that we're facing in fighting this epidemic. So we as healthcare providers working in our different settings, we have to figure out how we can bridge the gap between the healthcare setting where we work and the community that we're trying to impact. How do we bridge that gap? Well, first of all, we have to be involved in the community. We have to find out where our patients live, what the neighborhoods are like, what the schools are like, what kind of grocery stores are in the area, restaurants, and so on, and parks, where our patients are living, what the household setups are, and we must reach out beyond clinic walls to create community linkages with other institutions in our area, YMCA's, park districts, daycare centers, schools, and so on, to make sure that we're all working together to bring a healthier lifestyle to our neighborhoods. So one simple thing that we providers can start doing, and I know probably most everyone's already doing this, but it's very important that every time a child comes into the clinic, no matter for what reason, is to measure height and weight so we can calculate a BMI. Just looking at a child is not enough. We are often underdiagnosing obesity by just looking at children. We have to calculate BMIs and plot them on the growth curve. We have to start realizing who's around us. We have to know our local resources, and we have to make referrals. If we have patients with comorbidities, we need to find out what subspecialists are in the area we can refer them to. We have to find out what exercise programs or nutritionists are in the area, dietitians that we can make proper referrals for our patients. An interesting study that came out back in 2007 showed that we as medical providers do have an impact on our patients. It showed that 78% of overweight patients reported attempts to lose weight when so advised by a physician. Now, these were adults, but I think also as pediatricians, we talk to the parents of the children, we can have similar results. Only 33% of patients in the same BMI category attempted to lose weight if their physician did not discuss weight loss. So a personalized message as brief as 1 minute delivered by a healthcare provider has potential to significantly change patients' decisions and behaviors. I'm going to talk about that a little later, about how we can do that. Because like I said, when we do well child visits, we have 15 minutes, and we have a lot of obese patients coming in with cold symptoms and other things. How can we address that in 1 minute? I'm going to give you a little strategy later on. So now I'm going to shift gears a little bit, and after this introduction about obesity and the barriers that we're facing in our neighborhoods, I want to talk about my personal experience. I've been at Lawndale Christian Health Center for the past 7 years, and it's a not-for-profit health center founded in 1984. We're located in the North Lawndale community, the west side of Chicago, and our mission is to show and share the love of Jesus by promoting wellness and providing quality, affordable health care for Lawndale and the neighboring communities. We are a federally qualified health center. We serve underserved areas, communities in Chicago. That includes North Lawndale, which is primarily African American, South Lawndale, primarily Mexican, and then also East and West Garfield, and the Archer Heights community, as well as Cicero. We have currently 4 health center site locations. We're working on our 5th. That's in development up in Garfield Park, together with the Breakthrough Ministry. We currently have one dental clinic. We joined our adult together with our pediatric dental clinic in our new wellness center. We do have an optometry clinic and a pharmacy. We have 60+ medical providers spread over those 4 sites. And we have 8 full-time equivalent pediatricians. So here's some health statistics, or statistics of our patients that we saw back in 2011. So most of our patients are Medicaid and uninsured, smaller amount Medicare, and then because we serve mostly South and North Lawndale communities, 37% of our patient population is African American, and 59% of the population is Hispanic Latino, and of that, mostly Mexicans. A wonderful resource that we have in our clinic is the Lawndale Christian Fitness Center. It opened in 2005 as a response to figuring out how practically we can improve the health and wellness of our community. And then in 2012, we opened our new community wellness center, which now houses the Lawndale Christian Fitness Center, along with a cafe and a pediatric and women's health center. In this last fiscal year, we have seen a total of 11,563 3 to 17-year-olds, of which 21.4% were overweight and 23.5% were obese. So around 40% of LCHC's pediatric population is overweight or obese. That's why, in our clinic, and I'm sure it's true for everyone that works in these underserved areas, it can be quite overwhelming. Just seeing one child after the other with obesity. If they're coming in for a well child visit or for a cold or for other reasons, you're going to see a lot of obese kids, and we have to figure out how we can address it at every visit. Now I'm going to talk about our pediatric weight management program. that was initiated by one of my colleagues before I started, and then I took over about 5 years ago. So I run this program along with a pediatric nurse, and then we also have a dietitian, a psychologist on staff that we could refer to internally if we needed to, and then, like I said, we have the fitness center that we can refer our patients to as well. The way our program is set up, patients are identified by my colleagues, ages 2 to 18. They're identified as either overweight or obese. And I ask my colleagues to order fasting labs before they send them to me. Then they're internally referred to my clinic. I have about 8 slots allotted for weight management once a week for one session. And then when the patient comes for the first time, we explain the program. We tell them that we meet about 30 to 45 minutes once a month for 3 months. And if they finish the 3rd session, that they will get a prize. So hopefully that will motivate them to finish the program. But unfortunately, our show rates have not been so great. But what I really want to focus on is the individual families that we've been able to impact. But if you look at statistics, sometimes it can be a little discouraging. When the patient first comes, the intake questionnaire is completed, and then we do set some individualized goals at the end. Now, the approach that we're using is the motivational interviewing technique. Probably most of you are aware of this technique. Basically, it's letting the patient sort of take charge of the conversation, for us providers to relax and just sort of sit back and steer the conversation, and picking up on different things that we're hearing, and motivating the patient by empowering them to find out how to help themselves. So it's been actually a really great way. I'm going to talk about a little bit more about this a little later on. But basically, what it is, when the patient first comes, we assess the readiness for change. How ready is the patient and the parent ready to make changes in their lifestyle? We also obtain a detailed history. We get to know the patient and his surroundings. So we want to find out where the family lives, what the home setup is, where the patient goes to school, how many meals he eats there, what's the neighborhood like, can they play outside, etc. And who takes care of the patient, who takes care of them in the evening and the afternoon. And then we also elicit information from the patient and the caregiver. Instead of us talking so much, we want them to be talking about what they think are the problems, and we want to empower the patient and the caregiver to set their own goals and assist them in setting realistic goals that can be kept. It's interesting, when you let the patient talk, often they themselves, as they describe to you their living situation and the food they eat and so on, they often, at the end of the session, they realize where the issues are, and they come up with their own goals. And our goal and our job is just to make sure that the goals they set are realistic. Often they come up with very unrealistic goals. They want to, I guess, prove to us that they're ready to dramatically and drastically change their lifestyle. But it is our job to make sure that they're realistic goals that can actually be kept, because if they set unrealistic goals, they will be very unmotivated and discouraged when they come back the next time. So we help in setting realistic goals that can actually be kept, and then when they keep those small steps and small goals, they'll be ready to continue, and they're encouraged by that. I'm going to just show you our intake survey. This is actually something we got from Children's Hospital many years ago, and it's a detailed intake survey that we take when the patient first arrives. So we get a family history, we get a detailed beverage history, because beverages are often the hidden calories. People often don't think that beverages contribute to weight gain. So we ask specifically how many cups of sweetened beverages and how many cups of fruit juice does the child drink a day. Then we talk about portion size. How much food does your child eat? Do you think it's less than an adult, similar, or more than to what an adult eats? So it's just the perception of portion size. And then the second helpings, trying to get an idea of how much control the patient has over how much they eat. And then also the lifestyle, how many times this family goes out to eat. And then we also ask them some screening questions for eating disorders. If the patient eats in secret, if he's in control of how much he eats, and if he makes himself throw up after big amounts of food. So we screen for binge eating. Then we get a detailed history on screen time and also physical activity. And we also have a depression screening. We ask about irritability, sad, unhappy mood in patient and in parents. And then at the end, we have the parent and the patient give us 2 examples of things they already have been working on to be healthier. And then we also have them explain to us what they think some of the barriers are in their situation to be healthier. And that's where it becomes so important to get to know the family, because the barriers will be different for every family. So this is a summary of the things we ask about. The other thing that we talk about that's often not thought of is sleep. Sleep has shown to be very important. Kids that are sleep deprived have a higher risk of obesity for multiple reasons. TV in the bedroom is a big issue, so we always encourage parents to remove the TV from the bedroom and to actually get proper sleep, at least 8 to 9 hours a night. The way our clinic is set up is that we meet 30 to 45 minutes each session, and we meet with the family 3 times over a 3-month period. And each time when the patient comes with his caregiver for the 2nd and 3rd time, we review the goals that were set the previous time. We really encourage them, and we pick up on little positive things. Sometimes it's hard. Sometimes patients are unmotivated. They're not really making changes, but the important thing is to pick up on little changes and little positive things and really hone in on those things and try to build and to develop that area that they have made some changes in. And then also ask about some changes they've made. Usually the kids are pretty motivated. They've made at least 2 or 3 changes, you can note, or the parents. And then at the end of the session, again, new goals are set and old goals are reemphasized. Now I'm going to talk a little bit about some of the handouts we've been using. One great resource is the Consortium to Lower Obesity in Chicago's Children. They have their own website, and you can download a free handout that has the 5-4-3-2-1-GO message. When I was talking earlier about that 1-minute intervention, actually this is like a 30-second intervention. It's easy. When I see a patient that's overweight, no matter what they're here for, I give them the handout and I say, these are 5 things you can do to be healthier. 5 servings of fruits and vegetables, 4 servings of water, stay away from the sweet drinks, just drink more water, 3 servings of low-fat dairy products to make sure you get enough calcium, 2 hours max of screen time, and at least 1 hour of physical activity. So it's easy to remember. They can put that handout on their fridge or in their room so they won't forget. Some other handouts that we've gotten from Children's Memorial a few years ago. There's this nice one about portion size control. Gives little pictures of the hands, like the fist of the hand is the portion, the cup, and then depending on their age, it tells them how many, it's 4th cup or 3rd cup or half a cup, whatever, of fruits and vegetables and milk and bread and so on for all the different food groups. That can be helpful in talking about portion size control, and then also some good eating tips. Those handouts are available from Children's Memorial Hospital, now Lurie's Children's. The resources that we are using, like I said, oftentimes it depends where the patient lives. If they live farther away from us, we use ICAP, clock, other resources to show us where different resources are for patients in their communities. Now, thankfully, we have this fitness center in our own facility, so most of our patients do live close to us in our neighborhoods, so we can refer them to the fitness center. And like I said, each family that completes all 3 sessions of our fitness center get a 1-month free membership to our fitness center. And then hopefully the momentum we have built over the last 3 months will then continue, and kids and parents alike will go and work out in our fitness center. The other program that has come to Chicago recently that I want to talk about, that we also have had good success with at our clinic, is MEND. And MEND stands for Mind, Exercise, Nutrition, Do It. It's a program that was developed in the UK, and it's evidence-based. They published a study and they followed kids 2 years out after the intervention and showed that they actually maintained weight and BMI 2 years out. So it's a very effective program. We had a great success in a pilot study that we did end of last year. So it is, M stands for mind, change unhealthy attitudes about food and activity, exercise, keep physically active on a regular basis, nutrition, learn how to choose tasty, nutritious, and affordable foods that are good for health, and do it. Take action to maintain a healthy lifestyle for life. So it's a combination of exercise and then nutrition, nutrition education, and then actually getting families' attitudes changed about a healthy lifestyle. So it's a free healthy living program for children ages 7 to 13 who are above the ideal weight, and their parents and the caregiver, so either one parent or caregiver for each child. And it's an intense 10-week intervention, proven results in achieving a healthier weight for children's age and height, and this innovative program empowers children to get fitter, healthier, and happier. And then helps families change their eating and exercise habits to help improve their child's physical activity levels, nutrition, and self-esteem. And so families take part in a fun 2-hour session twice a week for 10 weeks. So it's a fairly intense program. It's 20 sessions in total, lasting 2 hours. So when the children first come, we measure their BMI, their waist circumference, their recovery heart rate. So what's done is we measure the heart rate. Then we have them run up and down some set stairs for a minute. Heart rate, again, is measured, and then after 1 minute. So we see how fast their heart rate recovers. And then there's also a questionnaire about self-esteem, and a score is given. And these measurements are taken at the beginning of the session and then at the end of the session. The pilot group at LCHC was a great success. We had about 15 participants. We had a more than 90% show rate for the entire 10-week period, which is incredible. When we first talked about this program, we were very skeptical because I had had such problems with my own weight management clinic and getting kids to come. So when we talked about 20 sessions over a 10-week period, we were skeptical, but we were very surprised. And I'll talk about maybe why we've had such good success with this program. It was a very enthusiastic group. Parents connected during the sessions with each other and the children also, and they did not want the program to end. So my theory is that this is positive peer pressure. What happened was the moms really connected with each other. They learned how to shop together. They learned how to cook better. They got a lot of new information, and it actually was this positive peer pressure that kept everyone motivated. And then also the kids, they all became friends with each other, and they didn't want it to end. And actually what ended up happening after the program ended, the kids kept meeting with the coach to do their exercise programs. And a lot of the moms also came and exercised together at our fitness center. So it was a really wonderful thing to see happening. And I also want to tell you about the recruitment that we did, because it's very interesting what we learned. First of all, we thought, how in the world are we going to reach the patients that will actually be motivated to participate in this program and actually follow through with it for 10 weeks? And so we thought about different methods. One was direct referral from providers. And as my clinic has shown, that's not a very successful strategy, because if we directly refer, oftentimes patients just think they're being dictated by their doctor, and they often don't take the initiative and the motivation to actually go and follow through. What we have found, what really, really worked, was mailings. What we did, we identified patients in a certain neighborhood that we wanted to reach, in a certain zip code, English speaking, and because we don't have a Spanish speaking group yet. And we mailed out letters to these families, and we got a tremendous response. We only have 15 slots. I think we must have gotten at least 30 to 45 calls. And so some patients were put on a waiting list, 15 patients were registered. And I think what's happening is once the family gets the letter and they pick up the phone to make a phone call, just by doing that, they're already showing us that they are motivated to participate in this program. And so those patients that were signed up through the mailings, we're having more than 90% show rate for the entire 10-week period, which is incredible. Mary Elsner wanted me to share some personal experiences, stories, or some anecdotes, and I just wanted to say, in general, it's been a privilege for me to work at Lawndale Christian Health Center for these last 7 years. For the past 5 years, I've been doing weight management, and I would say one of the main things that I've learned is just to sort of step back and hear what the family has to say. It's so important, especially in the first session when you meet someone for the weight management clinic, to really get to know and understand the family dynamics, get a detailed social history, who lives in the home, how much time does the child spend with each person, and then also all the other detailed information that we talked about. And then really letting the patient take control and the parent figure out how they can improve their life, and just sort of step back and be their coach, not being a dictator, not being a teacher and telling them, you know, here are the 5 magic things you have to do to become healthier, but sort of really step back and hear what they have to say and then guide them and encourage them in making those changes. The other thing that's really impressed me is the impact that we as providers do have on our patients, even the little kids. For instance, there was one patient, I don't remember even saying this, but the parent told me that I had told the child that she should only drink water and stay away from the soda. And she said, I think she was 5 years old, they went to a family party and they were offering her soda, and she said, no, I can't have that. My doctor told me that's unhealthy. That was impressive that this child remembered what I had told her a few weeks before. But so never underestimate the little statements that you make, talking directly to the kids, making little statements to the children, do make an impact. Of course, the teenagers, sometimes you have to treat them like adults, really get them involved as much as possible, going shopping with the parents, being involved in cooking, making healthy choices, instead of just the parents running their lives. The older the parents are, the more the patient has to get involved in the decisions that are made. But even the little 3- or 4-year-olds, there's little things you can tell them directly that you never know. It might really impact their life. Something little like you have to drink more water because the soda is bad for your teeth, or whatever it is. Very simple little messages. If you tell it to them directly, they will remember. You'll be surprised. So there's another story I want to share. There was a patient I recently, just yesterday actually, I saw a patient who was quite overweight, and he has full-blown metabolic syndrome, I just found out. And in getting a detailed history a few weeks ago when he came to see me for the first time, I found out that he drinks a lot of Gatorade and a lot of chocolate milk. And I just talked to them about the fact that sweetened beverages often have play a large role in weight gain. They came back for a follow-up yesterday to see me, and it was incredible. They completely cut out the Gatorade, completely cut out the chocolate milk. That's basically the 2 changes they made, and he lost 2 pounds. So that was encouraging, and that brings me to the point that I never focus on weight loss. I always focus on maintaining healthy weight, and I focus on attitudes, positive attitudes, and a healthy lifestyle. And I tell the parents, if you do these things, if you think about what you shop, if you read food labels, if you cook at home, if you do these things, increase fruits and vegetables, your patient automatically will probably lose a few pounds. But even if it doesn't happen, it doesn't matter. They're still going to be healthier. And I tell them, you know, I do show them, everyone that comes in, I do show the growth curve. I show them their height and weight and BMI, and I explain to them that for their age, what the normal weight would be, or I tell them that they have a weight of a certain age. So, for instance, a 7-year-old that has the weight of an 11-year-old, I tell them, really, to be healthy, you shouldn't be gaining any more weight until you're 11 years old. That gives the parent a few different perspectives to look at the weight of their child, and makes it more understandable for them. So those are the things that I focus on is generally the attitude of the family, and then also our attitude as providers, not to be dictators, not to be teachers telling them this and that is what you need to do to be healthier, but just step back, get to know the family, be relaxed, enjoy the time with the family, and then figuring out where they're at and where they want to change. The other strategy that that I personally have developed in screening out patients that are not motivated to prevent those kind of patients wasting my time in the weight management clinic is what I do is every overweight patient that I have, especially when they come in for a well child visit, I give them a fasting lab form. I give them a form for them to come back to our lab in a fasting state to check their complete metabolic lipid profile. What I check is lipid profile, liver function test, and fasting glucose levels. Those are the 3 tests I order, and then I have them come back in 2 weeks to follow up with me. If they follow up with me, that already tells me that the patient is somewhat motivated because they already did 2 things. They already went to the lab to get the blood drawn, and they have come back to talk to me. So those patients already are showing me that they're more motivated. I give them some more handouts and talk to them more and set some more goals for them. And those are the patients then I refer to the weight management clinic. And through that, I've been able to screen out patients that are unmotivated. But in general, patients that do show up to our weight management clinic, just by them being there, they're already showing us that they're somewhat motivated. When we ask them, how motivated are you to be healthier on a scale of 1 to 10, most families are above a 6. If they're 4 or 3, they're probably not going to be there. So they won't be able to give us that answer. So in conclusion, obesity disproportionately affects minorities and low-income families. And we talked about the barriers that patients in our community face and that we as practitioners face. And then primary care health clinics can change the lifestyle of their community. I'm going to end there. If there's any questions, we're going to open it up now for questions.
Okay, if you guys have, the folks who are on the call, if you have any questions, you could either, you can raise your hand, or what I can do is, and then that way I can unmute you so we don't have folks talking all at once. Okay, Dr. Estrada, I'm going to unmute you. Go ahead, Dr. Estrada.
Hi, thank you so much for that presentation. That was extremely educational and also very inspirational. And I was just wondering, with these visits that you have that are 30 to 45 minutes long at the with your weight management clinic, how do you bill for those visits?
Yeah, actually, the way we bill for it is we just list it as a obesity, so 278.0 code, and well child visit 20.2. So we're not actually getting reimbursed for the time we spend with the patient. It's a standard level 3 visit.
Okay. Okay, thank you.
Yeah, we are the thing is we are an FQHC, so we do get the sort of a standard reimbursement schedule. So there's no other special codes that we can use to increase our reimbursement. But I'm not an expert about billing, so but for us, because in FQHC it's a little easier. We just do the 278 and the V20.2 as a code.
Well, and I will say, Dr. Estrada, with regards to billing, I don't know if you were able to see it or if you've seen in your emails, we did have a billing and coding webinar and all the accompanying documents that went out a couple of weeks ago. And it is on our website, which I can send you the link to, which has information on how to bill and code for these types of visits to maximize your reimbursement. So I can go ahead and send that along to you, which might help.
you.
Okay. Okay, do we have any other questions? Okay. I actually have a question for you, Dr. Backel.
Yes.
I know that you have some amazing resources that are available to you sort of at your fingertips. Do you have any advice to physicians who might not have such easy access to resources? I know you mentioned Clock and a couple of handouts that you provide, but do you have any suggestions for folks who are looking to sort of improve their resources to distribute to their patients?
Yeah, there's several. Actually, the Clock website is a good resource for finding organizations in the patient's neighborhood. So what you do is you find, for instance, if your patient lives in Chicago, the city of Chicago, what you can do is you can find out exactly where the patient lives according to the part of the neighborhood, and then they have a list of resources for that specific neighborhood. So that's one thing I've been using. And then I know there's other, like on ICAP, we're working on resources that you can find depending on where your patient lives, different resources that are in that area. And then your local hospitals. Oftentimes your local hospitals might have a dietitian that works with kids, or they might even have a weight management program if there's a gastroenterologist there. I know, for instance, in our neighborhood, Mount Sinai Hospital is a resource that we've used. For instance, for morbidly obese kids, I have one patient that I just didn't know what to do with anymore. I sent over to Mount Sinai, where there's a surgeon there that does bariatric surgery. And then he's now involved in that program to get him ready for surgery. So it's just talking to your local hospitals, and then if there's YMCA's, for us in Chicago, the Chicago Park District is a wonderful resource where parents can go and find out about different activities that their kids can get involved in.
Great. Thank you so much. Okay, before we end, I just want to open it up one more time. Does anybody have any last-minute questions? Okay. Well, again, thank you very much, Dr. Backel, for the presentation. We greatly appreciate it, and thank you to those in attendance. And in case you would like to reference this presentation again at a future date, we will put this up on our website and within the LMS. So thanks again, everybody, for attending. Thanks, Dr. Backel, for the presentation, and I hope you guys enjoy the rest of your day.
It was a privilege.